So only thing one has to teach. That is the only important thing. Because many of those who are brilliant during their DNA, they stop teaching moment they get into practice. So we should never stop learning because life never stops teaching. So for this particular program, we have chosen the topic approach to multivalvular heart diseases. But still, in India, at least in public hospital, we see a lot of valvular heart diseases. All the coronary number one cardiovascular disorder, still see a lot of valvular heart diseases. So I will just get into the one should really approach these valvular heart diseases, particularly in the context of multivalvular disease. Multivalvular heart disease is commonly encountered in clinical practice, and proper assessment of individual lesion is very, very important. Not necessarily all lesions will be equally severe or equally moderate. One could be severe, other could be moderate. So decision making more often differs from cardiologists to surgeons. If somebody straight away goes to a surgeon, indications may be a little different, or the timing of intervention may be different. If they go through the cardiologist, then probably again decision making there is some difference. So decision making is more important than incisions. That's very, very important. And decision making is more important than interventions. So I think you have to keep this in background. And timing and type of intervention and surgery has to be properly decided, because it should not be too early, it should not be too late. And because we know that when you go for a valve replacement, you are replacing a diseased valve with another new disease, because artificial valve is considered as a new disease. And you should also look at the cost and long-term outcomes. So these are some of the important key issues you should always keep in mind whenever you are approaching a patient of multivalvular heart disease. And other key issues is understanding the hemodynamic consequences of one lesion or the other. Clinical findings and symptoms usually determined by the flow, by the pressure gradients, ventricular function, rhythm, and pulmonary hypertension. So this is, for example, you take mitral stenosis. The gradients are driven by the heart rate. So, and particularly your ventricular function is extremely important in regurgitant lesion, whether it's mitral regurgitation, aortic regurgitation, or for that matter, tricuspid regurgitation. And atrial fibrillation is more often seen with mitral valve disease, rarely with aortic valve disease. And presence of a proximal lesion leads to underestimation of a distal lesion. For example, if a patient has got a significant organic tricuspid valve disease, then you normally will have less symptoms of pulmonary venous congestion and less symptoms of pulmonary hypertension. And distal lesion may severity of a aortic stenosis with mitral regurgitation. Because in severe AS, LV systolic pressure is very high. As a result, LV pressure is passively transmitted to left atrium residual lesion. And at the same time, severe MR with severe aortic stenosis combination, more often they will have fatigue because of fall in stroke volume, so also on cardiac output. So hemodynamics definitely will take you into various decision-making issues. The etiology of multivalvular heart disease, of course, most common is rheumatic heart disease. And there can be a degenerative mitral and aortic valve disease. You can have degenerated aortic stenosis, which is pretty common in elderly population. They can also have mitral annular calcification. Then we can have multiple valve involving endocarditis. Sometimes we have seen satellite extension, aortic valve vegetation encroaching on mitral valve, and they can also have tricuspid valve vegetation, particularly if they are on intravenous medication or if they are drug abusers. Then some of the uncommon causes of multivalvular diseases is Marfan syndrome and collagen vascular disease. In Marfan syndrome, you can have what is called polyvalvular prolapse. It can be aortic valve prolapse, it can be mitral valve prolapse, it can be tricuspid valve prolapse. So all these things can happen. And congenital heart disease can be a shown complex where we have aortic valve disease and mitral valve disease congenitally. And carcinoid syndrome can valves as well as left-sided valves. And ileal carcinoid basically affects the right-sided valve, that is tricuspid valve and pulmonary valve. Suppose if there is a PFO or an AST, then it can come back. It can also involve left-sided valves. If it is a bronchogenic carcinoid, then definitely it can affect both mitral as well as aortic valve and some storage disorders. This is just for completing the list of causes of multivalvular heart disease. What are the aggravating factors leading to worsening of symptoms or over-assessment? I think this is where we have to give a lot of importance, because nearly 40 to 45% of patients with valvular heart disease do have anemia. Then pregnancy is aggravating, put is more, heart rate is more. Then atrial fibrillation with a fast ventricular rate. It has got a lot of relevance in patient with mitral stenosis. For example, mild mitral stenosis with a heart rate of 150 hemodynamically behaves as a severe mitral stenosis. So that is the reason whenever you are treating a patient of mitral stenosis, you need to really control the heart rate before properly assessing the mitral valve area as well as mitral valve gradient. Many a time it has happened, patient has got just a valve area of 1.7 or 1.8, gets into fast ventricular rate, and of course at that time what happened, they can present with even pulmonary edema, and also they will have pulmonary venous hypertension. You just control the heart rate, bring it down to 70, 80, then their gradient will be around, mean gradient maybe 5 or 6, and even the pulmonary digestive symptoms also come down. So that is the reason the rate-driven mitral symptoms were extremely common, particularly in presence of obstruction. Then thyrotoxicosis, active rheumatic carditis, then infections such as endocarditis and pneumonia, pulmonary embolism, chronic obstructive lung disease, asthma. Because these can be associated with the valvular heart disease, one should take into cognizance of all these factors before arriving at a final conclusion as far as assessment and decision making is considered. So what are the factors leading to underestimate of valvular heart disease? Presence of a proximal stenotic lesion. For example, MS with AS. This is the least common of multivalvular disease. In presence of MS, you can underestimate AS. And it's also true, in presence of AS, you can also underestimate mitral stenosis. And presence of organic tricuspid valve disease, yes, you can underestimate the left-sided lesions. Obesity and thick chest wall, emphysematous lung fields. So these are of some clinical relevance. So what are the principles actually? Are symptoms attributable to severity of valvular lesion? And whether there is a feasible, because nowadays we are doing a lot of valvular intervention. Of course, the most common is balloon mitral valvuloplasty. Then we have even TAVI, and feasibility of valve repair rather than replacement. These are some of the things we need to consider whenever you are contemplating some surgical or cath-based interventions. What are the factors determining the type and timing of intervention? So these are some of the things you need to consider whenever you are going to take a decision, whether it is going to be a cath intervention or whether it is going to be a surgical intervention. The most important is functional class. Then LV dimensions and LV function, very important, particularly in regurgitant lesion. Then presence of complications such as left atrial thrombus, pulmonary hypertension, right ventricular function is extremely important. This is one of the neglected aspect of valvular assessment, because RV dysfunction has got a lot of bearing on the surgical outcome of mitral or aortic valve disease. So RV function is as important as LV function. Then we should also determine what is the extent of organic tricuspidal disease and associated coronary artery disease or aortic root disease. In fact, in our own paper, nearly 6% of patients with valvular heart disease do have a coronary artery disease, and aortic root disease and dimensions are also important whenever you are contemplating an aortic valve surgery, because nowadays this aortic root replacement or the Bentall procedures are really streamlined with an excellent outcome. So various parameters are to be taken into consideration for deciding the ideal time for surgery or intervention. Appropriate case selection and decision making is required to ensure optimal surgical outcome. So the assessment of valvular lesion again boils down to our clinical examination. All those things are really important, still relevant. Although people say the stethoscope has become obsolete, definitely it has got an important role to play in the assessment of valvular lesions as well as congenital heart disease. So give importance to symptoms, functional class, and examination. And ECG, chest X-ray, they are extremely important. Then echocardiography is the virtually a gold standard for assessing the severity of lesion, for making an etiological diagnosis, and also for decision making, whether it has to be an intervention, whether it has to be a surgery, if it is surgery, whether it is a repair or replacement, and also for assessing the LV and RV functions, and also to assess the degree of pulmonary arterial hypertension and other things. So these are some of the basic things. I don't want to really enlarge upon those things. And stress testing, particularly regurgitant lesions, moderately severe lesions, whether moderately severe AR or moderately severe MR, you can always assess their effort tolerance, because some patients out of ignorance or out of fear, they tell they can't walk even 2 minutes, 3 minutes. But if you look at the echo, they're just moderate lesions, LV dimensions are almost within normal limits. Just to ascertain ourselves, we can put them on treadmill and look at their functional class and effort tolerance. And stress echocardiography, particularly, it will be useful. Dopamine stress echo will be useful in assessing patients with low gradient, low flow situations. And sometimes mitral stenosis, particularly with bradycardia, we underestimate the stenosis. The gradients will be less, and sometimes when patients have a lot of symptoms on exertion. Patients do have a lot of symptoms on exertion. So what we should do, because many times it has happened, although mitral valve area is coming to 1.2 gradient has significant symptoms. So you just ask him to do some sit-ups bedside about 15-20 times, and the gradient which is 7/4, a heart rate of 60, with a heart rate of 100, it becomes 25/14. So this is the importance of exercise echocardiography. Then today, cardiac catheterization has got a lot of limitations for cardiac cath in a valvular lesion. Of course, one is to rule out any coronary artery disease in a patient is above 45 plus, or basically for decision making, probably there is no role for cardiac catheterization as far as valvular lesions are concerned, unless you are contemplating a cath intervention in form of a balloon valvuloplasty or in form of either a TAVI or a MitraClip and all those things. Otherwise, probably echocardiography has virtually replaced cardiac catheterization as far as assessment of valvular lesions are concerned. What is the impact of RV on surgical outcome? I am just trying to stress on this particular aspect because it is the most neglected. We always talk about LV function and we don't talk about RV function because RV function is an important determinant of outcome in patients undergoing left heart surgery. In presence of RV dysfunction or RV failure, operative mortality increases from 5 to 11% and from 8 to 22% during follow-up. So operative mortality is also high, so also follow-up mortality is also high. That's the reason it is as important to mention RV function as we mention LV function. Improvement of symptoms is less common in multivalvular patients with a pre-operative RV dysfunction. So particularly if a patient has got a left-sided disease, mitral valve disease or aortic valve disease, if they also have a significant tricuspid regurgitation, even moderate tricuspid regurgitation, today the surgical dictum is to repair the tricuspid valve for a better symptomatic improvement and also for a long-term outcome. So if you look at the various combinations of valvular lesions in rheumatic heart disease, if you look at the combinations, the most common multivalvular lesions in rheumatic heart disease is MS with MR, next is MS with AR, third is AR with MR, and fourth is AS with MR, and least is MS with AS. So MS with AS is least, and MS with MR followed by MS with AR is more often seen, is the more often presentation of a multivalvular disease. So this is just a clinical relevance. Here is a patient with MS with ARs. Patient has severe mitral stenosis as well as severe aortic regurgitation. Particularly in this context, increase in LVEDP reduces the transmitral gradient, and your A2-OS interval will not be short despite severe mitral stenosis because LVEDP is high. As a result, A2-OS interval is not, you will not be able to assess severity of MS, and also other clinical things. In presence of MS, you don't get S3 or S4, and pressure off time is unreliable in assessment of mitral stenosis when there is an associated severe AR. Then MS with AS, the clinical findings, again, your symptoms are exaggerated. So I think in presence of MS, if patient has angina, if patient has syncope, you always suspect aortic stenosis. Or in presence of AS, if patient has significant symptoms of pulmonary venous hypertension such as PND, orthopnea, or atrial fibrillation, suspect MS. So this is how you should suspect MS in presence of AS or AS in presence of MS. Again here, because of raised LVDP, A2-OS interval is unreliable. And despite severe aortic stenosis, you will not get S4 in presence of MS. And there is attenuation of aortic gradient. We will be underestimating the aortic gradient in presence of severe mitral stenosis. MR with AS, this is already I have said in presence of severe AS and severe MR, patients will become symptomatic quite fast because of early development of pulmonary venous hypertension as well as pulmonary arterial hypertension, because your LV pressure is transmitted to left atrium because there is no isovolumic contraction phase in mitral regurgitation. So suppose patient has got both AS and MR. If there is an ectopic, clinically you can able to differentiate whether this whether the murmur is because of AS or whether his murmur is predominantly because of MR. If it is an MR following an ectopic, there is no much change in the intensity of the murmur. If it is an MR, if it is an aortic stenosis murmur following an ectopic, there is always increase in the intensity of the murmur. These are some of the clinical tips. So, grading of mitral stenosis, we are all well versed with that. Only ACC-AHA put even 1 to 1.5 as severe mitral stenosis because their body surface area is pretty big. Particularly in India, among all Asians where body surface area is less, probably 1 to 1.5 we have to consider as moderate, and less than 1 it has to be 1 centimeter. But as far as ACC-AHA, 1 to 1.5 is also considered as severe mitral stenosis. And the gradient, we are all well versed with that. Anything, of course, gradient is always driven by heart rate. So, for example, mild MS with a gradient of less than 5 at a heart rate of 150, the gradient will be somewhere around 20 to 25. So, this is an importance of rate control in patients with mitral stenosis. And only important point, digoxin has no role in presence of mitral stenosis in sinus rhythm. Beta blockers are the best rate controlling drugs in presence of mitral stenosis. And balloon valvotomy, of course, we all know it's the procedure of choice for symptomatic rheumatic mitral stenosis with morphologically suitable mitral valve. And this just to show very important here, if the valve is calcified, subvalvular apparatus and the entire leaflets, commissures are calcified, yes, this is a case for mitral valve replacement. And you look at the lower panel here, anterolateral commissure is calcified, posteromedial commissure is free from calcium, and echo score, Wilkins score will be around 10 to 12. And just to drive home the point, just because leaflet is calcified, that doesn't mean it is not a case for balloon mitral valvoplasty. Even if one commissure is free from calcium, in fact, in our own series, nearly 35 to 40% of patient had an echo score of more than 12, and we got an excellent result. So I think the short axis of the mitral valve is extremely important view for assessing the mitral valve for suitability for balloon, because the commissural morphology is extremely important. See, look here, anterolateral is calcified, posteromedial is free, and even if one commissure is split, that gives enough very good working orifice, and there will be a significant symptomatic relief. This is the important take-home message. What are the indications for balloon mitral valvoplasty in less symptomatic patients? I am talking about not symptomatic patients. If the mitral valve area is less than 1, if PS systolic pressure is at rest more than 50, and on exercise more than 60, episodic pulmonary edema, and thromboembolism in moderate to severe MS, and pregnancy with even moderate to severe MS to be considered early. And indications for surgery is densely calcified valve. I think bicommissural calcification is very, very important. If there is a bicommissural calcium, that's what I was emphasizing on the short axis of the mitral valve. If both the commissures are calcified or extremely fibrotic, if you take them for balloon mitral valvoplasty, invariably there will be a leaflet tear, because the least resistance normally is across the commissure. But if commissures are fibrotic, then least resistance is not across the commissure, it is across the anterior mitral leaflet, resulting in severe MR. You can always write down if there is a bicommissural fibrosis, if there is a bicommissural calcium, even if rest of the leaflets are free from calcium, definitely they develop post-procedure acute severe MR due to leaflet tear. And predominant submitral disease and associated moderate to severe mitral regurgitation. So this is just an example. This is a patient for tight mitral stenosis and severe aortic regurgitation. And classification of left atrial thrombus, I think it's all in textbook. One can always, our students are well versed with that. Only thing, take home message is presence of left atrial thrombus is not just a contraindication for doing a balloon mitral valvulotomy, provided the morphology of the mitral valve is suitable. We need to define where is the location of the thrombus. If the thrombus is confined to LA appendage, or if the thrombus is confined to a LA roof above the plane of fossa ovalis, still we can do a balloon mitral valvotomy carefully, because either by over the wire technique where you don't maneuver much in the left atrium, and you can always come out with a good valvotomy result without risk of embolization. This is a ball valve thrombus. It's an absolute contraindication for balloon mitral valvotomy. So these are some of the types of left atrial thrombus. You can see here it is an appendage thrombus, so you can still do a balloon valvotomy. And here there is an appendage thrombus protruding into the body, but it's above the plane of fossa ovalis, still you can do. And here there is a thrombus along the atrial septum, it's a contraindication. And of course, ball valve thrombus is a contraindication. Here is a case scenario: 24-year-old female daily wager laborer presented with functional class 3 dyspnea, palpitation, and blood pressure was 130/70, and had a MDM at the apex, long early diastolic murmur, and ECG showing left atrial enlargement and a sinus rhythm. And the echo findings was mitral valve area 1 centimeter, mitral valve gradient 26/14, and LA appendage clot protruding into LA body, but above the plane of fossa ovalis, and score 9/16, no commissural calcium, and PS systolic pressure is 80, and LV dimensions, S is 3.6, and D is 5, E of 55%, and the diagnosis was severe MS, LA clot type 1B with severe AR, sinus rhythm. So here is a decision making, whether this patient requires a double valve replacement or whether we can do open mitral valvotomy. Unlikely, because there is a open mitral valvotomy with an AVR. Whether we can do an hybrid procedure, that is balloon mitral valvoplasty, then subsequently aortic valve replacement. So these are the management strategies: OME with AVR, or a double valve replacement, or PTMC with AVR. So this is, I just wanted to know, anyway, our Dr. Ranjan, who is a great expert in LA appendage closure, you can see here how far, here is the mitral valve and here is the appendage. So left atrial appendage is far off from the mitral valve. So if you try to avoid the appendage, if you don't maneuver much in the region of the appendage, then you can still do a balloon mitral valvotomy despite a clot in the appendage or in LA roof above the plane of fossa ovalis. See, this is what we have resorted to over-the-wire technique here. So after a septal puncture, rather than putting this spring guide wire into the left atrium, we have put this wire into the same spring guide wire into the left ventricle. See that there is an optimal coiling of the wire. Then I can, that means you are not playing in the left atrium at all. So most important aspect of over-the-wire technique here is when 2/3 of the stretched balloon crosses the mitral valve, you need to really withdraw the balloon, stretching tube. Otherwise, your spring guide wire from LV will come back to LA. That is the important technical point. When 2/3 of the stretched balloon crosses the septum, we need to withdraw 2 to 3 centimeter the balloon stretching tube. Then it curves and curls towards the mitral orifice. Then you can always do a balloon valvotomy as you do in other cases. So this is a case. Actually, you can see we did a balloon mitral valvotomy. Anterolateral commissure is nicely split, and posteromedial is partially split, and gradient was less. Then this patient, there was a mild MR that was not significant, and this patient underwent elective AVR. See, whole objective of doing an hybrid therapy is DVR, operative mortality is more. Even the 5-year outcome is also is not that favorable. So to convert a double valve replacement into a single valve replacement, here is the role of hybrid therapy. Then case scenario 2, 40-year-old female presented with a functional class 4 and dyspnea, extreme fatigue. See, in patient with valvular lesion, if there is an extreme fatigue, it is always because of decrease in cardiac output and fall in the stroke volume. Either it is a severe MR or there is a severe right heart failure. So either a severe right heart failure or a severe MR. And any patient with a multivalvular heart disease has got ascites, jaundice, always think of organic TB disease. So this patient had mitral stenosis and patient had tricuspid stenosis. You can see heart is big. The right atrium is markedly enlarged, also left atrium, and CT ratio is close to 90%. And you can see here, patient has got mitral stenosis. There is a spontaneous echo contrast, and the apical fourth chamber, you can see here a organic tricuspid stenosis. So this is what? Severe MS, severe TS, moderate TR, moderate AR, in atrial fibrillation, congestive cardiac failure with large LA body clot. I think a large LA body clot and patient is extremely symptomatic. I think this is where we have to go for surgical intervention. So whether it could be a DVR because patient has got MS, LA body clot, and also open if the valve, reasonably mitral valve was morphology was not bad, they can always do a open mitral valvotomy, aortic valve replacement, and a TB repair. Of course, other option whether we can do a balloon mitral valvotomy as well as balloon tricuspid valvotomy. But in this case, because there is a large LA body clot, this is ruled out. So in this case, this patient, of course, when we talk about open mitral valvotomy for stenosis, always surgeons say definitely we'll do a open mitral valvotomy and an aortic valve replacement. Then they come back and tell us the mitral valve was pretty bad, so we replaced both the valves. So case 3 scenario, 24-year-old male presenting with class 82 and BP 130/80, and there was a pansystolic murmur over the apex and EDM. That was not really a long EDM, just diastole, and ECG was not remarkable. And symptoms in form of fatigue, breathlessness, and the background of mitral regurgitation and aortic regurgitation. And this patient was double evaluation is important. Always you should see whether the clinical symptoms are matching with the clinical findings, matching with the ECG, X-ray, and echo. ECG was unremarkable. There was no cardiomegaly, no pulmonary venous hypertension. Look at this. Patient has got just mild regurgitation, is hemoglobin 0.5. So this today in this days of technological explosion, we do more often HbA1c rather than HB, because you look at various investigations. More often they talk about HbA1c rather than the importance of thorough clinical examination, and you have to put your mind into your thoughts into your mind. So this patient has moderate MR, moderate AR, and LV dimensions were normal PA pressure, and symptoms were exaggerated because examination. So indications for surgery in severe AR, I will talk about only asymptomatic individuals. If there is an LV systolic dysfunction, despite asymptomatic AR, there has to be a surgical intervention. And what are the indications for AVR in asymptomatic individuals? We all I will not get into that. What are the indications for AVR in aortic stenosis? Symptomatic, it is straightforward. In asymptomatic, severe AS, if there is an LV systolic dysfunction undergoing surgery for other valve or a CABG, yes, patient, aortic valve need to be treated. And third important indication for surgery in asymptomatic severe AS, if their NT-proBNP levels are high. If NT-proBNP levels are high, then we have to consider an early 125. If it is more than 5 meters per second with calcified valve, and progression is going to be very fast, there also have to consider surgery despite patient being asymptomatic. If they are undergoing surgery for other valves or CABG or elevated NT-proBNP 3 to 4 times, yes, they have other surgeries. Then low flow, low gradient AS, greater than 30. So you have to subject them, because we want to know whether the problem is in the valve or whether the problem is in the muscle. If the problem is in the muscle, they will not be benefited by surgery. If problem is in the valve, if the gradient increases, if the peak velocity, yes, they are benefited by surgery. If the peak gradient or the peak velocity does not increase by more than 25%, then doing a valve reading, you are doing more. So this is just for, indications list. Surgery for asymptomatic MR, chronic severe MR with LV dysfunction is an indication. See, we have this formula, what is called 60-40s. 40 for MR, the ejection fraction more than 60. A normal ejection fraction in severe MR is not normal. A normal ejection fraction in chronic severe MR is the indications for surgery in chronic severe MR with preserved LV function. One is new onset atrial fibrillation, hypertension more than 60 with exercise, and progressive LV dilatation on serial follow-up. These are some of the indications for surgery in asymptomatic severe MR. Indications for tricuspid valve surgery. Severe TR in setting of surgery for multivalvular disease should be corrected. Severe primary TR when symptomatic, and prophylactic tricuspid annuloplasty for asymptomatic mild to moderate. Even a moderate TR, mild to moderate TR, it should also be given surgical attention in patients with left heart surgeries. I think just I will spend another 5 to 10 minutes. One of the important complications of valve replacement is paravalvular. Dr. JAYADEVA group has done a device closure of mitral paravalvular leak. This is a 51-year-old male diagnosed with mitral valve prolapse with severe mitral regurgitation 6 years ago. And mitral replacement was done with St. Jude mechanical valve, 27 mm, 2015, and was doing for 4 years. Complained to drugs and regular PTINR checks. So as far as anticoagulation issue was, and patient was on a very good PTINR control, and functional class progressed from 2 to 3 in the last 1 year. Fatigue and palpitation also in terms in last 1 year. So then these are some of the important the prosthetic valve was okay, but problem was this patient was symptomatic with dyspnea, palpitation, and fatigue, grade 3 pansystolic murmur at the apex, radiating all over the precordium, and LV was had. So this was the X-ray cardiomegaly. You can see, and patient was extremely symptomatic. See, the usual symptoms of significant paravalvular leaks. One is yes, there are fatigue, palpitation, or breathlessness, and another will have LDACG shows LV volume overload with T-wave inversion V1, V2. And this is the echo. You can see here, of course, I will come back to color on transesophageal echo. Echo, the PSP was somewhere around 63, and the gradient was 20/8, and ejection fraction was okay, and LV dimensions 5.8 astral LVID, S was 4.1, and IVC was dilated and partially collapsing. So this is, you can see here, left atrium is pretty big, and there is particularly this is a two-chamber view. You can see a severe mitral regurgitation. So there were two commissures. One is anterolateral and posteromedial, and regurgitation through the orifice was insignificant. This is 3D TE on the LA side. So the plan was obviously a device closure. The approach was, we were wondering whether it should be transeptal or apical, and device choice say this Amplatzer vascular plug, 18 to 20 millimeters. We have two types of Amplatzer vascular plug, 2 and 3. So you can see here, this is an LV angiogram, significant paravalvular leaks. It's not through the valve orifice. You can see another one is, here is an anterolateral commissure, and this is a posteromedial. See, particularly if the paravalvular leak is in the posteromedial, it's very difficult to go by a transeptal approach. Even for that matter, even if the paravalvular leak is in the anterolateral commissure also, it takes a lot of time. Transeptal technique takes a lot of time. In fact, Dr. Subhash Chandra, when ourselves, we have done a couple of cases transseptal. In fact, once Dr. Subhash Chandra came to Jayadeva, did one paravalvular leak, and it was closed with ADO2. I also did one, and since then, in fact, he was quite a pioneer as far as this transapical device closure of paravalvular leak is concerned. See here, just about 2 centimeters, the pigtail is kept in the LV apex, and the puncture, LV apical puncture was taken just maybe 1 centimeter medial to the pigtail loop here, because this has a significant advantage, because this MR jet itself will take your guide wire through the leaks. So by Seldinger technique, the LV is centered, and of course it is always to be monitored under transesophageal echo guidance. And see here, this is confirmed on transesophageal echo, both 3D as well as 2D. So this guide wire has passed through the your guide wire has not gone through the orifice of the valve. So 20 millimeters AVP. One has to be absolutely sure you are not across the valve orifice, very important, before deploying the device. It was checked. So when it was, see here, this AVP2 was occluding and MR has come down significantly. It is not obstructing the valve. Then it was decided to close the paravalvular leak in the posteromedial commissure. And extremely difficult to come down from the transeptal because you will not get the angle. It always goes towards the, even if you take Judkins or even if you take Mullin sheath or various other sheaths, it's very difficult. It's extremely time consuming, long you have to spend. So this was deployed. So then, after closing both the leaks, you can see here, make sure that there is no residual paravalvular leak. LV angio shows there is no leakage. There is no leakage either through the orifice or through the paravalvular leak. It's nicely occluding both the paravalvular leaks. Then next important step is, yes, because you've gone through LV apex, medial to the LV apex, we need to close this rent by ADO2. So these are some of the hemodynamic data before and after. And you can see here the PA pressure, it was 60 by 30, dropped to 45 by 18 immediately. And LA pressure also came down significantly. It was echo. LV, will show the echo gradient. You can see here the mean gradient dropped to 7. Virtually, there is no mitral regurgitation, paravalvular regurgitation. And disc movements are fine. That is extremely important because valve. So these are some of the literature. I will not get into that because already we are close to 9 o'clock. So the most complication that you can enter if there is a residual paravalvular leak, still it can have hemolysis and prosthetic valve interference. Need for emergency cardiac surgery also can be there. Device embolization is an issue. Pericardial effusion, if you are not properly closing the LV rent, it can be an issue. So 5 days post procedure, patient stable, of course, there was no issue and was discharged. So this is the X-ray. So the take-home message out of this particular paravalvular leak closure with the device, transapical approach for mitral paravalvular leak is a safe procedure with a very high success rate, reduces procedural time, advantage over the conventional approach for medial defects, particularly medial defect. It's extremely difficult to go by transeptal. It has to be transapical, mandatory to ensure adequate the valve leaflet movement before deployment. Prosthetic valve leaflet movement has to be extremely important. We should watch before deploying the device. So the conclusion is proper clinical examination and echocardiographic evaluation is mandatory in assessment of multivalvular lesion. Timing of intervention should neither be too early nor too late. And mitral valve repair for MR and PTMC for mitral stenosis should be considered in all eligible patients. In multivalvular disease, hybrid therapy is an important option, and preoperative assessment of tricuspid valve disease with RV function assessment is mandatory in multivalvular disease. TAVI in non-rheumatic eligible cases should also be considered. Yes, with this probably we can add some, not to add quality to their life, we can add also life into their years, and also we can add years to their life. Thank you.
Thank you, Dr. Manjunath, for a wonderful presentation. It's an extremely vast and difficult topic. Making it, you really summarized it very well, sir. Thank you. So, 1 or 2 questions in the chat box, sir. One question is about ivabradine in hypotensive MS patient where we can't use beta blockers. So the question is about role.
I think evaporadine better to avoid. If a patient is not tolerating beta blocker, you can use even diltiazem.
True, sir. Yeah. And it has to be probably only in sinus rhythm.
Correct.
And then probably, yeah. One more question by Dr. Anuradha. MS versus M.
No, in fact, AF is a bit rare in isolated MR. Of course, as age advances, it can come. Definitely, it can come. But particularly the atrial, LA thrombus is in both the cases it can occur. It's more common with mitral stenosis. Symptoms are concerned, the atrial fibrillation with a fast ventricular rate will deteriorate symptoms of mitral stenosis more than mitral.
And there is one more question, sir. Difference in management of severe MS in rheumatic heart disease and mitral annular calcification.
Yeah, mitral annular calcification. See, of course, if it is a native mitral stenosis, that's what this thing. If the valve, it's the management, right?
Yes, sir, difference in management.
So definitely a balloon mitral valvuloplasty is a very good option if the valve is suitable, this thing. But in mitral annular calcification, there is a case for your percutaneous mitral valve replacement because we need something to hold. See, the indications for percutaneous mitral valve replacement is if it's a post valve repair. If there is a ring, it can still hold. And if annulus is calcified, you can still take mitral valve, percutaneous mitral valve.
Yes. Thank you, sir. Any other question from anybody? Dr. Ayeng.
I think thank you, Dr. Manjunath, for the next talk, which we've been waiting for. And thanks a lot for sparing your time. And you rightly emphasized a few points, which I also like very much. One is the RV is an orphan organ. So please pay attention to the RV functions. And secondly, you mentioned about how the ectopics help you in your clinical assessment of, say, MR and aortic stenosis, and the hybrid procedures where don't alone, instead of convert the DVR into single valve replacement. And lastly, of course, you talked about the importance of stethoscope and the organ that lies between the two ear knobs. So it's very important. So stethoscope is very important. So I thank Dr. Manjunath for sparing his time and giving us such an excellent picture about the multivalvular disease. Thanks.
One more question about MAC, sir. Is there any role for anticoagulation without AF?
I think without AF, there is no indication.
No, yes.
Yeah.
Dr. Patil, any comment?
No, sir, it's a masterly talk from a master, and we have enjoyed it. And he has given a lot of tips to the students. Great talk. And he has already told to preserve the valve as much as possible, and if possible, do the hybrid procedures. I think that is a great message and holistic approach, including the anemia, heart rate, all these things have to be taken into consideration, including the comorbidities. A great message, a great talk.
Thank you, Dr. Patil.
Yeah, thank you, sir.
Very nice to hear your voice.
Thank you, sir. Great.
So,
Dr. Patil has worked with us with lot of sincerity, commitment, dedication.
Thanks, sir. Thank you, sir.
Yeah.
Thank you, Dr. Manjunath, for such a wonderful. Now I request Dr. Iyengar to give a vote of thanks, and then I think we'll close the session.
No words to thank Dr. Manjunath. Taking time off from his extremely busy schedule, and I'm grateful to him, and so is the student community and cardiology student community. And I thank Dr. Manjunath again. Thank Dr. Ranjan and Dr. Patil and all other delegates who joined in. And thank the Manipal team for the technical arrangements. Thank you once again. Thanks, Dr. Manjunath, once again.
No, thank you.
Good night, sir. Good night to all. Thank you. Take care.
Recording.